the letters.
I think we'll get started.
So this is good to me.
Thank you all so much for coming and being here to talk about this really important and impactful topic. And I want to thank Dr. Levine for being here too. I'm Representative Kate Nugent from South Burlington. And we've got a number of representatives who could maybe just introduce themselves super quickly and then we'll get started right away. Because I know we have a really important topic and I'm sure people have lots of questions too. So without further ado, we can start with.
I'm Reverend Young from here in Montpelier. Representative Burkhart from South Burlington as well.
I'm Rev. Hartford and a member of the steering committee for the Public Health Caucus.
Representative Candace White, I live in Waitsfield.
I'm Representative Territory. I live in Moortown.
Representative Michelle Boslin, Wyndham 3, Northern Wyndham County.
Representative Wendy Critchlow from Colchester.
Representative Sarita Osmond from Colchester.
Hey, with anyone in the chairs, if you wouldn't mind just briefly saying who you are, and I think that would be nice too.
Oh, sorry, I mean naming, and I'm pretty lifelong public health professional since I've been a professional. Working public health, but I recently relocated here to Austin and working with people. Although I'm a lawyer, advocate. Denise Smith, I'm the executive director of the Vermont Council on Rural Development. I'm also the treasurer of the Vermont Public Health Association. So,
Do you want to go?
Yes, my name is Jeffrey Hirschman. I'm a director of H12, obviously I have a patient. Lead on the Public Health Association here in Vermont. My background is in healthcare and
So I'm Molly Lawrence Shepherd, and I'm the board chair of the Vermont Public Health Association. And I'm also Indian Health and Community Health. I'm a committee assistant in building interested in
I'm Kristen Barron, and I'm on the policy committee with the Public Health Association and also a committee assistant for housing and healthcare.
Awesome.
Hello, me, John O'Brien, represent Royalton and Tunbridge.
So much. All right, without further ado, Dr. Levine, thank you so much for being here.
Thank you.
Oh, and I think I can introduce Dan. Dan,
Yeah.
And
also executive director of Vermont Public Health Association.
So don't the senators know they're invited as well?
Oh.
You go there, huh? I won't go. So the title of the talk before the comma is what I was asked to talk about. And I couldn't really do that without what follows after the comma. So put your seatbelts on and we'll go through this really quickly. If the clicker, do I have to point it at something? Oh, there it is. Yeah, okay. Okay. It works fine. So this is not budget testimony, but I want you to notice that out of our $226 million budget at the Department of Health, there's that huge yellow swath of 40% federal funding. But don't be deceived, it's really closer to 60 or 70% because the turquoise blue is global commitment Medicaid. So the dark blue is state general fund. So we are very dependent on the federal government. I could end the talk right there. We'll move on and show you our department. These are the divisions of our department, and I'm going to just briefly go through each one. And apologies to those who may have seen these slides at recent testimony, but I'm going to focus very differently on them in terms of what we do and how the federal funds interplay. So starting with our environmental health division, basically that's just what it says, keeping us protected from environmental threats. So we have a lot of lead programs, one in partnership with the state of Vermont through the legislature, which is safety of drinking water in schools. But obviously lead's history is in paint and in homes. and most of the healthy home work is federal funded work. We have, unfortunately, even though it's the greatest public health threat of all time, which is climate change, we have 1.3 FTEs because most of our workforce depends on the federal monies coming through CDC, and that's what we get. So that's obviously a very vulnerable area. We are very concerned about the air we breathe and the water we drink. The PCB program, that's well known to most legislators here now, is really much more state funded than federal funded. Though there is a little bit of EPA mixed in that. And PFAS and other substances in drinking water, there are environmental threat grants we get through the federal government that are very important to support a lot of that work, though there is a state component to that. In the environmental health arena, there's things like radon as well that have significant federal funding. Family and child health, I'll move us through to the bottom two items. Home visiting programs, that's a McV kind of program, which is a federal grant program. We have major Title V federal grant funding that comes every year to support the majority of the work in family and child health. And then the WIC program, which everyone's familiar with for mothers and their infants and children and nutritional concerns, is of course a federal program. COVID and laboratory sciences and infectious disease go together, but COVID is but one example, because obviously we have a whole army of epidemiologists. We have a huge public health lab, and all of the work they do is infection related, infection control and prevention related, as well as surveillance work. And when it comes to it, outbreaks and pandemics are really require the personnel in that division. Most of that is federal funded. Out of our epidemiologists, I'd say 90% are reliant on the federal payroll. Laboratory, also there are some significant grants that enable us to do surveillance work, work with new pathogens, work with things like we're doing now with testing all hospitalized influenza A patients for avian influenza as well. Hospital labs aren't going to do that work. That's what the public health lab does. So a lot of stuff in there. And then our whole immunization program, very, very federally dependent.
Is it okay to ask? Karen?
It is, but I won't get through them. Because I made the promise that I will make sure we have abundant time for questions. Substance use programs. The state of Vermont is almost unique in the fact that we get several $1 million a year, even before cannabis was around, to do prevention work in substance use. And now we get more because cannabis has been successful. No comment on that. But the reality is most of our money for substance use, whether it's prevention, intervention, treatment, or recovery related, is from major federal grants and from obviously clinical services and Medicaid funding. So very dependent. This just shows that we have local health all throughout the state who put on a lot of clinics that are all related to the divisions we've talked about. The whole area of chronic disease prevention, healthy aging, health promotion, disease prevention, we rely on federal monies for that. I wish I could say the federal monies, this division, are as robust as some of the other divisions, but they're not. So the division is very vulnerable because it has so much federal funding, but as part of our department, it's not the same vulnerability as places that get more. But there are so many important programs that are in this arena that are very important to the health of Vermonters. And then emergency preparedness, again, thinking about pandemics, thinking about disaster responses, like we've had too many of in the last several years. very much federal programming. Injury prevention is underfunded nationwide. It's again money that comes through the CDC and comes to state health departments. So when you think injury prevention, we're talking suicide, falls prevention. We're talking a host of things like firearm safety. These are things that don't have huge budgets, but the budget they have is usually better. And then finally, we are the place that has data and maintain a lot of statistics, registries, vital records, look at surveys all the time and provide results so we know what interventions we're doing, if they work, they don't work. All the grants we have with CDC and other federal players are always carved out to have a portion going to the data part, which is so critical. So that's like a very quick run through of our reality. Now we'll go through a little bit of the current reality we're all living through. And the organization of this is going to be, I'm going to talk a little bit about WHO and USAID, and then I'm going to get into the health and human services arena and drill down to some of the things and vulnerabilities in that arena. So just to put us on a playing ground, the World Health Organization, this is from their website. I didn't make up their definition, just so I could be transparent for them. But basically, that first sentence reeks of equity all over, everyone having an equal chance to live a healthy life. That is what public health is. Can't take equity out of public health, no matter how hard someone might try. It loses its whole foundation. Who leads global efforts to expand universal health coverage, direct and coordinate the world's response to health emergencies, using science-based policies and programs? So potentially inflammatory language, if depending on the reader, but certainly not this audience. The fact of the matter is, the World Health Organization is a critical part of outbreak surveillance, pandemic surveillance, disease surveillance in general, and the interplay between our CDC and WHO is very robust and strong, or at least it has been. So what are the implications of withdrawing? Well, first of all, withdrawal doesn't occur with an executive order. It takes a year still. There's a process that has to be gone through. But a lot can happen during that year. And part of what happens during that year is local personnel, maybe CDC personnel, suddenly find themselves leaving and coming home. So they're no longer boots on the ground in the areas of the world that they were in. Fortunately, some of that is remaining. So there's a major Ebola outbreak right now in Uganda. And CDC actually has an outpost there. So they were very tightly yoked to the Ugandan public health professionals when this was all unfolding, and providing tremendous amount of guidance and work that was critical there, so that they could come to calls like I have every week with state health officials around the country and in our territories and say exactly what's going on right now. So the US has to start preparing about travel issues, about sequestering people in airports, whatever, limiting the number of airports. We're going to be like, oh, of course we're ready for that because we've been hearing it all along. And it's just now's the time we're pulling the trigger. So losing that kind of frontline engagement is really challenging. The early outbreak notification is really a critical thing. You know, we've got a lot of things going on. Clade 1 Mpox, this newer version of Mpox that is far more virulent than the M2, the Clade 2 version. How do we know about those things and worry about what happens in North America when we don't have as much surveillance going on, or the support we give the organization that does that surveillance has suddenly been cut by almost $1 billion. Very, very important. a lot of the training of local personnel happens through what we do on the ground in those different countries. Everyone talks about the fact that for the US to have health security, we require partners internationally to have that security before we can have it, because so many things now are coming from elsewhere to us. So if you want other countries to be secure from their health standpoint and to be economically stable and not subject to disruptions in democracy and what have you, we all need to be in this together. I will also say that WHO isn't just an infectious disease organization, it's a public health organization. So chronic disease is part of its portfolio, and it's really important. So I put up the bottom line. Our future, as I've said in any talk, is about emerging infections and new threats to health. And lacking data in an early warning system can't be good. USAID is defined again on this slide, and I won't go into everything, but it's disaster response, helping countries not sustain poverty, but become more prosperous, and democratic reforms in countries around the world. And this statute places the organization under the direct authority and policy guidance of the Secretary of State. And look at that portfolio: global health, disaster relief, socioeconomic development, environmental protection, democratic governance and education. All of that is big stuff, just like WHO was. And if we dismantle that, that's again going to harm national security here, and that's not a good thing. So right now, there's a limiting waiver for sort of life-sustaining services, but there's a lot of confusion about what's included in that. And there was a very abrupt, everybody come home kind of thing and leave where you are. There was a very abrupt, no more funds for X, Y, or Z. One of those X, Y, or Zs was PEPFAR, which is the program that's going to eradicate AIDS, or was going to. But right now, people are lacking medicine. The clinic's closed. They don't have the supply of medicine. People's viruses will become resistant. People's infectivity will suddenly reappear. And there we go. Can't be a very well-informed decision to let that happen. And this whole issue of soft power that organizations like this represent, where we can actually do good things and be perceived as the good guys and not be displaced because we've cut off services, be displaced by some of the authoritarian regimes around the world. That can't be a good thing either. So here's Health and Human Services. It's not everything in there, but the things I'm going to talk about: CDC, FDA, CMS, SAMHSA, which is mental health and substance abuse, and then NIH. So first thing that everybody heard about was the implications for communication, whether it be verbal, written, doesn't matter. The proclamation that things will be off of websites if you don't use certain words anymore, etc. So that's all real to a point, because web pages were removed if they referred to vaccines, gender issues, climate change, you name it. The communication with WHO has been more immediately impacted, which can't be a good thing. YRBS survey and other survey instruments had sentences or questions removed. And we use those every other year to compare trends and compare what's going on in our youth and know if any of our programs are working, etc. Well, that can't be healthy if we suddenly lose data points on things that we know people need to talk about because it impacts their livelihood or their life sometimes. I mentioned we heard from CDC right away about the Ebola thing, and we continue to be able to get people to talk to us from there. But a lot of it is not now self-generated by them. It's we have to request, and then we'll get it happening. It's not as much like we want to come to you now and tell you this. It's a very different environment. And the technical guidance that clinicians, that public health officials, that the public needs doesn't go away. So it can still happen, but we're told by colleagues that layers of approval are required to make it happen. And then cancellation of some conferences because they dealt with immunizations and 50% of the faculty were CDC and they said they couldn't participate. Their MMWR is sort of gearing up again and we're getting more published than was before, but there was a vacuum for a period of time. And with avian flu being really what our focus is on, there are some important papers on avian flu that we're just seeing now that probably would have seen a month ago. States don't exist in isolation. We need to have the recognition that pathogens cross borders all the time. And we need to be able to coordinate with one another. And CDC helps us do that. And then these are just some of the health threats that are of concern because we need to have information yesterday, not 3 weeks from now. So the season for the human flu is thriving nationwide to degrees that have not been seen in years. We have the specter of H5N1, the avian flu. In Texas and now spilling over to New Mexico is a major measles outbreak in a disease that supposedly was eradicated in this country. The Ebola outbreak I mentioned in Uganda, and then the Mpox clade. And that's just the tip of the iceberg. I won't worry you with other things. Other risks and implications regarding CDC is that there's been a talk about dismantling it. Maintaining its infectious disease profile, which is fine. But as I pointed out with our health department slides, we rely on CDC for abundant things besides infectious controls. So there's a short list: injury prevention, firearm safety, suicide prevention, health equity, gender affirming care, immunizations, emergency preparedness, the whole environmental health arena. And we have block grants that are public health block grants that cover a whole array of these things. And they cover the infrastructure, which CDC was actively working on for itself and for state health departments, the whole data modernization acts, the whole workforce development pieces. These are critical pieces that we have grants for that we need to continue to make it thrive and not have go their own way. If we listen to the trial testimony of RFK Jr., we would say, well, maybe we don't have to worry about chronic disease or healthy aging or tobacco control because he's all over that. But I haven't heard a thing since he actually got appointed. Not a thing, not on the positive or negative side. So we don't really know where his mind is, but we do know where DOGE has been cutting positions, and that crosses all agencies. And then I'm very concerned in our laboratory surveillance and infectious disease section about just the things that are listed on the slide. Going beyond CDC, so the CMS for Medicaid and Medicare, if there are changes in the Medicaid program, that's really of concern because they are major population health programs. So you may not think of them or look at them that way. That's exactly what they are. And there's a whole arm of CMS called the Innovation Center, CMMI, which is why we're going into a head, and they work with other states and other health reform arenas. I don't know if that will still exist. I do know that the relationships already in CMS have changed because some people aren't there anymore. So that either they weren't there because they left because they saw the writing on the wall, or they left because they are part of the recent firings. But people in my department and in the Agency of Human Services have noticed that they don't have the same contact and they don't have a contact. So that's a concern. NIH, the National Institute of Health, we think of in the research arena. They've had travel bans, conference bans, study group bans, meetings, and the whole issue of this indirect cost, which hasn't been sorted yet. But if that goes the way it's been proposed, the real story is Harvard does have an endowment that could handle that, but how many universities and colleges in the country have a Harvard endowment that will take care of what the indirect costs provide, which is really the infrastructure to do the research in those facilities that they have. And then you may have heard about food safety with FDA and regulating food packaging, chemicals in food, infant formula, a lot of things that people in the FDA are telling us are at risk. I'm not just saying hypothetical. These are things that are at risk, and some of them related to some of the recent job transitions that people have had. Now, I should note that Vermont is one of the 22 states in a lawsuit, and there's been a temporary restraining order on some of those information issues and communication issues, but not everything. And so we did see web pages come back with big headings that say it's dangerous to read them because they'll have bad information, but they came back. I've been very carefully following the one web page dealing with transgender care, and it didn't go away. So I thought that was promising, but we shall see. Last couple of slides here. So the impact of current firings. People don't always know what people do who work in all of these parts of HHS. And the one that impacted us recently was the Epidemic Intelligence Service, EIS, which is really, again, another boots on the ground, whether it be in the US or in a foreign country, to deal with major outbreaks and things that are of concern. We have a health officer in each year of their class, and we didn't lose them thus far. Other states have told us they've lost people. And there was a tweet that had some very angry comments in it from people who were concerned about losing the EIS because of what it does and how valuable a service it is. And there was a rather unprofessional response in that tweet by the owner of Twitter or X that basically said, it's not true and stop bullshitting. But other states have told me their EIS officers are gone. So that's all I know. Agriculture and the egg industry has been in the news a lot because the egg industry has really had a lot of disruption because of the avian flu and culling of flocks. So that's really a challenge to lose people who are involved in trying to help sustain them. And then just because we haven't heard from RFK Jr., all I have is quotes from prior and during his proceedings, which are cleaning house, returning gold standard science, which I don't understand because we have great gold standard science. He just hasn't chosen to believe it. And then restructuring, streamlining, and efficiencies, which is sort of the party line. And this is our last slide. This is just I'm using that division again, Elsa, to just be the example of the concerns that we have. And again, I'm not trying to alarm anybody, and it's certainly not my staff, but I also can't be falsely reassuring about things that I don't control. So status of no-cost extension of COVID funds. We have some COVID funds that we currently have an agreement can go through 2027. And those are mainly personnel. I hope they stay good in the no-cost extension. We have a 5-year cooperative agreement with CDC, which covers tons of different things. I hope that stays true to its name. The vaccine program is the ACIP, which is the advisory panel to the CDC about what to do with vaccines. Which ones to recommend, not recommend, which ones should be as part of the Vaccine for Children program, VFC. All of that potentially could be up to disruption and chaos. And be based on some things like, does this state have entry requirements in their schools for certain vaccines? Maybe they don't get funded or do get funded. Who knows? we thought we were, I mean, we're always dealing with misinformation and disinformation, but never because it came from the very top of HHS. So that's a new playing field for us. Our epidemiology laboratory capacity grant is really paying for a lot of the epi and infection control that happens and our ability to respond, which is, as I said, highly federally funded, as is our laboratory flexible funding model grant, which specifically focuses on our ability to respond to acute things going on and to do surveillance. So that's a whirlwind tour, and I'll stop because you get the first question if you remember what you wanted to ask, but otherwise, I invite questions.
Thank you so much.
I've actually changed the question I was gonna. Just a little bit more about what it means to lose funding for, like flood recovery. So I live here in Montpelier, and what I see after the flood, what I saw, beside something that looked like a war zone, were neighbors helping neighbors, community people coming out, Montpelier Alive, organizing things under tents. But I'm wondering, like, what was happening behind the scenes where federal funds were being used
Yeah.
to return our community to something we can.
Right, so a lot of that is disaster response type money focused very much on the disaster at hand. And then there's the whole bucket of FEMA money, which is the one that people are very concerned about. And our senators have been very outspoken about it because there's talks of, well, we don't think FEMA does anything. They don't do what they're supposed to do. So why don't we just get rid of them? So they're very concerned about that, obviously, which is, when those volunteers are doing their work, they're doing it with the eye to, there's gonna be money to get this business back on its feet again. There's gonna be money to get this person into a home again or into this home again after X, Y, and Z have happened. And that's FEMA. From an environmental health standpoint, I hope we wouldn't change much of what we're able to do. But just thinking about some of the things we do, you know, a lot of it is messaging about the dangers of the disaster you've been through and how to move forward and avoid some of those. But a bunch of it is testing your well, since 40% of Vermonters don't have public drinking, and making sure there's no bad things in your well. That's a program we do through a lot of federal funding that supports some of that kind of stuff. So there's layers of things, some of which would be directly affected, some of which wouldn't.
Well, and read the hospital association. Vermont has a universal vaccine program which is funded in part by federal. Are we worried about that being affected?
Yes. But, you know, I don't know where to put it on the worry scale. You know, is it red alert or is it sort of just like a yellow blinking light? You know, it's hard to know. Because again, we haven't heard anything since the appointment occurred. Other secretaries have said all kinds of things since they were appointed. And his appointment came like right after his hearing was over. So it's kind of weird to me that we're not getting any signals. But yeah, there's a concern. Now there's a lot of work that goes on in that program that is federal, but there's a lot that we purchase through a federal contract, and that insurers then pay us for. But it works so well in Vermont that it'd be a shame to see it disrupted. And especially if it was disrupted because we want MMR vaccine to be part of the mix, and that might not be hypothetical.
Mike Fisher, healthcare advocate. Looking at the news of the polio outbreak in Texas.
Measles.
Measles, sorry. Measles.
But that's another one that could happen.
Yes.
A vaccine preventable disease.
Is there anything that we should be, is there anything that Vermont should be doing in recognizing Texas is not that far?
Right.
They have-
So the good news is, if you look at our rate of school K through 12 vaccine for people, kids in school, we're in the 94-ish to 95% range. So that's still herd immunity range. Doesn't mean we couldn't have a case of measles in Vermont, but we won't probably have a huge outbreak in Vermont. Now, we had 2 experiences this summer with imported measles cases. And I want you to clap for my LCID division and others in my department, because no Vermonter was impacted, even though there were plenty of us. That's incredible. But these things can happen. What happens in places like Texas is it's probably not imported, but it's under-vaccinated communities. So like even in Vermont, I have to say, if our rate is 95%, there may be pockets where it's 80%, whether that's an ethnic community, whether that's a religious community, whether that's just people who are non-believers and vaccine skeptics. It doesn't matter, but if you have a pocket, you can get more than a case. It'll spread through that part of the community.
Other than like prevention, which is huge, and intervention, like for everyday Vermonters seeking healthcare.
Yeah.
How would this impact?
So the only thing that would impact them in healthcare is if some of those changes to Medicaid occurred. All right. And I don't want to tell you what those changes are, because God knows what that could be, but the leading one is always the work requirement. That's sort of the one that's put on the table first, because it's been put on the table for other programs besides Medicaid. So I don't know what that would do. I do know that Medicaid is about 1/3 of the population of Vermont. And if you isolate it just to kids, it's like 50%. So we're talking a lot of people. So if something was done to Medicaid that was very disruptive, the state wouldn't have the resources to just throw at it and say, we can replace these. It's a big proposition. So that part I could say for sure. Otherwise, from like an information standpoint, we haven't changed our website one bit. We haven't changed any of our grant renewals to CDC one bit. We're going to make sure they tell us if we need to change something, rather than we just kowtow and change something and send it in, because that's against our values. And we still have not changed our values.
I think we have to wrap up because there's another meeting in here in a couple minutes. But sure, yep.
Just one question. A number of years ago, before your tenure, the legislature changed the requirement for the commissioner of health to be a doctor.
Yeah, well, a little bit. They didn't change it drastically. You could be a nurse, but
I said, do you have a comment about that? Appreciate your service, and we're gonna be looking for a new one, and
we are looking for.
and you have a comment that change in the requirement.
I think Vermont is well served by having doctors in the position. I'm aware there was one nurse practitioner in the position, who I also know. That was fine as well. So I don't think anyone suffered by that. I think the benefits outweigh that. I think in the times we're in, you need a pretty broad base of knowledge and skills to do the job. Even though I'm the first to say I need a village, I didn't come here as an expert in PFAS, but you need to be a quick study and all that to do that. But you need to be able to accommodate just so many different aspects of public health, and understand the healthcare sector and be able to try to integrate back and forth with the healthcare sector. So I think it's a healthy thing to have it that way.
Thank you so much. And
Yeah.